Hello, RDs and RDs to be. Welcome to the RD Exam Ready podcast. I'm Zach Caseberg, your tutor, coach, and guide along the path to passing the RD exam. If you want to learn more about passing the exam or just want to learn more about the exam itself, then hey, you're in the right place because I love to help RDs and RDs to be just like you to know how to better dominate this thing. Now, if you're a student, it seems like you've liked what I've done, whether it's Domain 1, Domain 2, quite a bit. And I understand why. I like doing Domain 1 and 2. And never neglect Domain 3 and 4, though. That's one thing just to remember is you never want to neglect 3 and 4, or it will burn you. And speaking of burns, I thought today might be a good day if we look into the MNT of critically ill and burned patients. Now, you may say, Zach, they all seem critically ill from my experiences, but no, we mean like ventilated, ICU, unstable, and unable to eat sometimes. Today, I'd like to discuss this critical care, specifically to conditions of metabolic stress, sepsis, and burns. Before we do, I just want to plug the show just a little bit. I want to remind you just to tell friends, family, other students that you know that are studying who want to follow this show. They can do so wherever they listen or watch podcasts. If you want to follow me on socials to see more questions and other content, you can search RD Exam Ready Podcast or RD Exam Ready for Instagram, YouTube. Maybe I'll do something on TikTok if I ever find out what anyone would want to see me do on there. But just wanted to plug that a little bit and get that out of the way. So check those out on all those platforms if you would. Thanks. Let's start by talking a bit about critical care and how things kind of occur here. We're going to start with the ebb and the flow phase. The ebb phase is this 2 to 48-hour window after injury or trauma. What happens is you get this shock that results in hypovolemia or low kind of amount of volume in the blood. And you also end up with decreased availability of oxygen because your body's in shock. You're not doing so well here. During that ebb phase, your metabolic rate drops. And that might seem a little bit confusing, but yes, in fact, your metabolic rate does go down when we're in this shock phase. We also see reductions in blood volume that leads to decreased cardiac, decreased urinary output, cardiac output, and really what you're seeing is big drops in blood pressure. Now, as dietitians and a medical care team, what you're focusing on is stopping bleeding, restoring blood flow, and maintaining those oxygen levels for this patient. For us as RDs, our role is purely to help support the medical team, but usually we want to make sure that they're getting some form of IV fluids because that's going to help maintain their blood pressure by pumping them with some fluids there. For the flow phase, this is where you're in this hypermetabolism, catabolism, altered immune, and hormonal response stage. Now we're kind of at this good phase where we're past that 48-hour shock window. Now the patient is starting to heal and get a little bit better at this phase. They're starting to build up those tissues again because we really don't want at this phase as RDs, we want to make sure that that hypermetabolism that they're going through doesn't worsen their already vulnerable nutrition status. Because if they continue to not eat or not eat well while they're healing, they're not going to get better anytime soon. So this is where we can start to interject and make our foothold in there too. Kind of a third phase is known as the recovery phase. The recovery phase is where you get this resolution of stress with more of a return to anabolism or build up in normal metabolic rate. We're continuing to feed the patient, but this is basically that recovery phase where, maybe they've been discharged from the hospital, they're doing at home stuff, and they're trying to maintain their nutrition status at home. Still very important to the healing process, especially when it comes to wound healing, but we're kind of out of that ebb and flow by this point. Now, we're going to go point by point with each of these kind of disease condition states, and we're going to start with metabolic stress because it applies to all of these different concepts here. Starting with assessment. When you're assessing a patient who is metabolically stressed, you need to take a few things into consideration. One is that a lot of the time they're going to be completely unconscious, so you may never be able to speak with them and ask, how were you eating before you came in? How were you eating before your car accident that you had, right? And a diet recall is usually something we really rely on to help know if they were meeting their needs, but you don't have that. Another thing you'd have to consider is the patient on a ventilator or not on a ventilator. That would determine how we're going to feed them, more than likely, as well as it would help with some of the different predictive equations that we can use. There's different equations, such as the Penn State formula. That was always my favorite. That can be used to calculate the nutrition needs for a patient based on their ventilator settings. So that would be a great situation in which I would rely on that type of predictive equation to find that patient's needs. If they're not on a vent, maybe I can go with a different predictive equation, such as Mifflin, where I could calculate their needs. In general, if you ever need just a back pocket reference of calorie recommendations for a metabolically stressed patient, more than likely 25 to 30 kcals per kilogram would be pretty decent for someone with a normal BMI. For an obese patient, though, this would be a little bit too high. We don't want to overfeed a metabolically stressed patient. So we would rely on something a little lower, maybe a predictive equation that works better for an obese patient. Maybe we'll choose something like 22 kcals per kilogram for ideal body weight. But even better, I think if you could find a predictive equation, that would be good to stick with here. What about protein needs for a metabolically stressed patient? What would you guess? We know that zero point 0.8 is about that normal healthy adult. 1.2 is kind of like a little bit mildly stressed. So, what I would say is for protein needs, you're going to be looking at 1.2, likely up to 2 grams per kilogram of actual body weight for those protein needs. Now, that would be a good fit for someone who is a normal BMI, maybe a little underweight. But if someone has an obese or a stage 2, stage 3 level of obesity, we're not going to use 2 grams per kilogram to calculate their needs, especially not for their current body weight. We may use the 2 grams per kilogram based on their ideal body weight to give us more of an idea of how much protein that they require for their body to maintain their protein status. Now for our intervention. If a patient could meet their needs orally, then we would do that most of the time. But a lot of the times in hypermetabolic states, the patient can't meet their needs orally. So we prefer to rely on nutrition support. What would we want to rely on? Enteral, parenteral, both? Well, ideally, we would want to start by using enteral nutrition because enteral nutrition would actually feed into the stomach if we do, or the small intestine, and that's going to help to maintain that gut microbiome, the gut permeability, to help keep its function working really well. If the patient was unable to meet their needs enterally, then we would definitely have to rely on parenteral nutrition as our next backup there. If we can do enteral feedings, we can talk about some formulas that might be good for a hypermetabolic patient. Most cases, per aspirin, normal polymeric standard formulas can work just fine for a critically ill patient. But if they have a fluid restriction or fluid resuscitation, or they have other severe comorbidities, which is typically what we see, we're probably going to choose a different formula that provides different amounts of micronutrients and macronutrients. For these micronutrients, the amino acid glutamine is one I might want to keep in your back pocket. Glutamine is the sole fuel of your enterocytes. Isn't that fascinating? And it assists in helping to maintain that intestinal membrane and the permeability. Glutamine is found in most of your enteral formulas already, but you could add it supplementally. Excuse me. You could add it as a supplement if you wanted to. Other nutrients you would want to include for that metabolically stressed patient would be omega 3 fatty acids, vitamin C, vitamin E, selenium, zinc, and probiotics would all be very good because a lot of these different things, like our omega 3s, vitamin E, and vitamin C, all of those are antioxidants, right? So, this is something great to include for a patient who is in a very inflammatory state. And then many of those minerals that I mentioned will also help with wound healing and overall amount of inflammation in the body. So they're great ones to include there too. All right, metabolically stressed has set us up for the rest of these conditions. Let's talk sepsis. I'm I'm going to give you a couple different definitions of sepsis just to see if it helps sticks it for you, because I always have to come back to it every once in a while. Sepsis is a large immunosuppressive process, and what's occurring is the body is not adequately responding to an infection, and this can lead to a range of conditions like systemic inflammatory response syndrome, also known as SIRS, as well as it can commonly lead to organ failure and death as a result of sepsis. Here's a second definition that I got from my text. I have sepsis. Another definition we can use is sepsis is a life threatening organ dysfunction caused by dysregulated host response to infection. In other words, your body is not responding correctly to an infection. Let's see about how this goes about happening though. What you're going to start with is that infection, okay? That infection or trauma. The cells recognize that there's trauma, that there's infection, and they start to go into action. They recognize this. When they see that infection in there, we get this large release of inflammatory markers, right? Huge, big inflammatory cytokines really just trigger off right there. And that kind of amount of inflammation, what happens is that leads to vascular permeability, where your blood vessels are not really maintaining the kind of permeability that it should. We want the blood vessels to be able to control how much fluid, minerals, micronutrients, things that pass through, electrolytes. And when we're in sepsis, they're not able to do that. So, not very good there. With sepsis, it's a trauma response. So, similar to the hypermetabolic state that we just discussed, we're going to have this large rate of catabolism, of gluconeogenesis, of breakdown of skeletal muscle, and things are just not going to go well for this patient if we do not get their SIRS or their sepsis under control. For nutrition therapy in sepsis, we're going to follow a lot of the same guidelines we've just learned. We need to control the inflammatory response as well as reduce any muscle breakdown, and if needed, we need to support that wound healing process. The organs, they're dysfunctional, but they still require calories, they still need protein in order to function, so we need to give them that. Calorie and protein recommendations for sepsis are going to be the same as that for that hypermetabolic state that we just discussed. So stick again, 25 to 30 kcals per kilogram for a normal BMI patient, or better yet, we're going to rely on predictive equations, and we're also going to have elevated protein needs there too. When it comes to nutrition support in sepsis, just follow this. If we can meet it orally, great. If we can't, we need to initiate enteral nutrition. And if we cannot initiate that due to system dysfunction or the GI tract not being able to do that or aspiration, then we need to rely on parenteral nutrition, which could further cause systemic issues too. Now, let's get into our burns for our third and final topic here. Burns are usually the result of some type of heat injury, electrical injury, a boiling injury. And as an RD, when I think of a burn, I really think of wound healing and your ability to feed yourself. Burns are usually classified by the depth of the burn, as well as the amount of surface area that it takes up on the body. The pathophysiology for a burn is going to follow actually the same as that metabolically stressed patient. They're going to go through an ebb phase, a flow phase, and a recovery phase. But especially for a burn, since they're going to have so much exposed tissue right at the beginning of this phase, in the ebb phase, they're really going to be getting a lot of focus on amount of fluids they get and amount of hydration, because with all this large surface area of exposed tissue, you're at just a much higher risk of becoming dehydrated and at a much higher risk of infections, as we know there too. Once the patient is out of that ebb phase, through the flow phase, once they're in recovery, um, let's say that this patient has not been eating for 5 days. Okay. So let's say they came in with their burn, they were put NPO, and they haven't eaten for 5 days. What are we going to do? Well, we would have initiated early enteral nutrition as early as possible, maybe within that first 2 days if we could have. Because we know that they need to heal their wounds. We know that Their organs aren't working correctly, likely, and we know that as they're healing, their skeletal muscle is breaking down. So we need to provide adequate nutrition in order to prevent these things from happening. You could use a predictive equation to estimate the amount of energy that a patient would require if they have a burn injury. And the amount of energy that they require would probably kind of closely correlate with the level of injury, the amount of burn, and how high of a hypermetabolic state that they're actually in. For me, if I were to choose calorie needs as kind of predictive calorie needs, I'd probably choose 30 to 35 kcals for someone who is at a normal BMI. Protein recommendations, I'm definitely going to bump those up. I would say 1.5 to 2 grams per kilogram of ideal body weight would be a good fit for someone with burns. You can kind of play with the numbers and see what works best for them. For micronutrients, here's a couple I'm going to list off: glutamine, zinc, selenium, vitamin C, and vitamin E. All of these help to provide some benefits to wound healing, so that's why they're ideal for a burn patient. This nutrition delivery, whether it's enteral, whether it's oral, hopefully not parenteral, we need to provide it in a quick manner. So, obviously, when we're in the ebb phase, we're probably not feeding them. But once they're shifting out of that shock phase, in that first 24 to 48 hours, we want to feed them. We want to get them nutrition of some kind so that they can start healing. One thing to be considerate of, though, is that if a patient is even conscious, if they're even awake, we might not be able to provide that oral feeding, so we would have to rely on that enteral there. If you were going to place, an enteral tube of some point, you would also think of things like, well, where are their burns? Do they have burning throughout their throats? Is it going to prevent us from placing a nasogastric tube? These would be the types of things you would just probably want to consider if you're going to do enteral, oral, parenteral, or a combination of all these. Okay, RD to B, you've made it this far. Think you're ready to apply it to a question? The ebb phase is characterized by A, increased metabolic rate, decreased oxygen availability; B, increased metabolic rate, increased blood pressure; C, decreased metabolic rate, decreased blood pressure; or D, increased metabolic rate, increased oxygen availability. The ebb phase is characterized by which of these four? Let's write out A, B, C, and D and pick out what our best answer is going to be. For A, increased metabolic rate, decreased oxygen availability. Well, what I remember from the ebb phase is that I have a lower metabolic rate in the ebb phase, okay? So I know any of these that say increased metabolic rate, probably not going to be correct for us there. For decreased oxygen availability, I think that fits. Usually they're not going to be breathing so well when they're in the ebb phase, so I think that fits. I would get rid of A though, because it says increased metabolic rate. For B, increased metabolic rate, increased blood pressure. Well, I'm going to get rid of B as well because I know it's not going to be increased metabolic rate, it's going to be decreased metabolic rate. Additionally, I don't think my blood pressure is going to go up when I'm in this phase. I think it's going to go down more than likely when I'm in shock. For that reason, I'm going to get rid of B as well. C, decreased metabolic rate, decreased blood pressure. I like this answer. I know my metabolic rate will decrease, and I know my blood pressure can tank when I'm in the ebb phase. I'm going to put a little check mark by that. And D, increased metabolic rate, increased oxygen availability. Well, just based off what we talked about previously, we don't see increased metabolic rate, so this one's going to be a bad fit, and I'm going to get rid of D. That means that the ebb phase is characterized by C, decreased metabolic rate, and decreased blood pressure. Number 2. A patient who is 6 foot tall and 180 pounds is admitted to the ICU with severe burns on over half of his body. Which protein prescription would fit best for this patient? Okay, so let's look at the patient. They're 6 foot tall, 180 pounds. What's their BMI? I'm curious, it doesn't sound like they're obese, but let's kind of take a look here. So if they're 6 foot tall, I know that I can convert that to meters, right? Because 6 foot is 72 inches. If I wanted to convert inches to centimeters, which is just how I do it, I would do 72 times 2.54. Okay. When I get that, I get about 183 centimeters or 1.83 meters. Then, if the patient is 180 pounds, you can divide that by 2.2 pounds to find out how many kilograms they weigh. So this patient weighs about 82 kilograms. Now, if I just want to double check, I just want to be like, all right, let's see what their BMI is. And their BMI is right around 24 to 25, so pretty normal here. I'm not concerned that they have obesity here. But let's look, based on their weight of 81.8 kilograms, let's see which protein prescription would fit best for this patient. I would think that I want to aim for something like 1.5 to 2.0 grams per kilogram. So I'm going to go ahead and I'm going to check that out. Let's do 1.5 times 81.8 kilograms. That gets me 123 grams of protein per day. And then let's do the same with 81.8 grams times 2 is going to be about 164 grams. Okay, so we're looking at about a range of that for our answer. Let's see what these answers look like here. For A, 82 grams per day. Well, that's a little bit low, I would say. It's about half of what we need. I'm going to get rid of A. B, 115 grams per day. Even for our low end of 1.5 grams per kilogram, 115 grams is still too low. Our kind of lower range we had was 123 grams. 115 grams is close, but I don't think it's good enough. C, 160 grams. Okay, this is within my range. I'm going to hold on to that one. And D, 205 grams. So if I'm stuck between C and D, my best answer to me is going to be answer C, because it's closer to the range of the protein needs that I calculated. 205 grams of protein is a good amount, but we don't want to overfeed the patient. And so I would say for this 6 foot tall patient, 180 pounds, who's admitted to the ICU with severe burns over half his body, I would recommend this patient get 160 grams of protein per day. Number 3. A patient has been admitted to the ICU following a motor vehicle accident. They were admitted 5 days ago and have not received any food or nutrition support since admission. They have bowel sounds but are unconscious and able to eat. What should the RD recommend? Let's read that one more time. A patient has been admitted to the ICU following a car accident. They were admitted 5 days ago and have not received any food or nutrition support since admission. They have bowel sounds but are unconscious and able to eat. What should the RD do? All right. So A, B, C, and D. A, recommend to the doctor to start TPN. B, change their diet to a regular standard diet. C, wait and continue to monitor the patient to see if they wake up. Or D, recommend to the doctor to start enteral nutrition. All right. So the patient hasn't been eating for 5 days. They have bowel sounds but aren't able to wake up. Let's see what we should do for them. For A, recommend to the doctor to start TPN. I feel like it's a bit early to start TPN. If the patient has bowel sounds, then we should be able to initiate enteral nutrition or oral feeding if possible. I don't think A is a good answer, and I'm going to get rid of that one. B, change their diet to a regular standard diet. Well, hey, this sounds like a good idea. Only problem is the patient is unconscious. So what good is it going to do if they don't wake up to look at their regular standard diet? I would get rid of B because I don't think we need to wait any longer to get this patient nutrition. C, wait and continue to monitor the patient to see if they wake up. This is not a good answer, and I would get rid of this as well. We're already at 5 days without nutrition. The patient is going to really start to lose a lot of their muscle mass over this time, so I don't think this would be a good fit. D, recommend to the doctor to start enteral nutrition. This would be my best fit, and this is the one that I'm going to choose for my patient that's been admitted to the ICU following a car accident. After 5 days of no nutrition or nutrition support, after having bowel sounds and being unconscious, the best thing that the RD could recommend would be for the doctor to start enteral nutrition for this patient. That wraps up today's lesson, students. I hope you listened, learned, watched, and enjoyed. We had a really good show kind of talking about these different concepts. Remember that passing this exam is a journey. We all need assistance along the way. Do me a favor, hit the subscribe button, tell a friend or a study buddy, rate, review, and help spread the word. And as always, happy studying to you, RD to be.